Oh. Okay, thank you very much. Really, you are here.
Good afternoon, everyone. Actually, in this post-class session, though who are present from morning, I will go through the recap only. Actually, this topic is discussed in previous lectures also. So my topic is vagus nerve stimulation, candidate selection, safety, and regarding the efficacy. We already discussed that the vagus nerve stimulation is a palliative therapy, that is the adjunct treatment for drug refractory epilepsy. After 1997, when it was US approved by US FDA approved, then near about 1 lakh VNS surgery was done in all over the world. In 1 lakh, near about 30% are childhood population. And it is the first neuromodulatory device approved for epilepsy. In UK, also with VNS, there is a trigeminal nerve stimulation also approved for pediatric epilepsy. But in USA, only VNS is approved in pediatric age group, that is less than 18 years. We all know that VNS suppresses epileptic seizure, prevents emotional disorders, and improves cognition. I will go through one case. That is 6-year-old girl, perinatal history died immediately after birth. The birth weight was 2.5 kg. But on day 3, there was neonatal hypoglycemia with seizure. And after that, there was no seizure, but infantile spasms started since 6 months of age. And the infantile spasm was treated with ACTH, valproate, and clobazam. And with ACTH and the seizure was passive in between. And seizure was passive for 2 years. But for last 3 years, she presented with intermittent tonic seizure and drop attack. And for that also, they tried with valproate, lamotrigine, clobazam, topiramate, and pulse methylprednisolone. MRI shows the bilateral parieto-occipital encephalomalacia. That is the telltale of the tail sign of the neonatal hypoglycemia that leads to in later period. The EEG like that is the slow spike wave, and also the PFA. So our diagnosis is LGS, Lennox-Gastaut syndrome. There is no doubt regarding that. The diagnosis is Lennox-Gastaut syndrome, and we have tried with valproate, lamotrigine, clobazam, topiramate, and pulse methylprednisolone. Then the question arises, what next? That is the question, what to do and when to do, what should be the precautions, what should be the contraindication of the procedure, and what other seizure to be benefited with that procedure. Then we all know that is the treatment sequences. We usually go for LGS or any other type of seizure, we usually go for first monotherapy, second monotherapy, and if that is not effective, we usually go for the polytherapy. And if that is after 2 years of the polytherapy and in 2 drug in adequate doses, we usually term that is DRE, that is drug refractory epilepsy. So when we stamped a case as a drug refractory epilepsy, you usually go for the next investigation, and is she or he is a candidate of epilepsy surgery or other procedure. If she is a candidate of epilepsy surgery, proceed for that. That is a surgery, and if she is seizure free, well and good. But if she not a candidate of epilepsy surgery or epileptic surgery is not appropriate, then next procedure is VNS only. That is VNS therapy. And if the targeted seizure type dramatically improved, continue with VNS. And if that not improved, so revisit and reevaluate for epileptic surgery. That is the what to do. Then when to intervene? Earlier is better. Always earlier is better. as the lesser cumulative seizure loads may improve the patient's chance of recovery. And also there is a decreased AED therapy load, and that improves the cognition and other behavior in cases of childhood population. Due to a higher degree of neuronal plasticity in children. There is a observational study where they compare the early versus late. Early, they recruit less than 6 years of on anti-epileptic therapy, and late they recruit more than 6 years. They recruit 405 patients. In 405 patients, 51 were the early group and 354 in the late treatment group. And they show that the seizure reduction of 100% was reported in 7.8% in early group and 3.7% in late group at 3 months, and 11.8% in early group and 4.5% at 12 months. That is statistically significant. So earlier VNS, there is a chance of less seizure in cases of VNS therapy. Our third question was, what was the should be the precautions? Already that is discussed. That is the cardiac dysfunction. In cardiac dysfunction, usually as the right vagus supply the SA node and left vagus AV node, there is every chance of bradycardia and asystole in cases of cardiac dysfunction. Second one is obstructive sleep apnea. It increases the chance of dyspnea and also the apnea. And third one is sleep. In one article, they write regarding there is chance of daytime sleepiness, but recent article says that there is daytime alertness is better in cases of VNS therapy, and it also reduces the REM sleep. What should be done in cases of if there is some sorts of OSA or sleep or cardiac dysfunction is there? We have to lower the stimulus pulse width and frequency and increase the off time. What is the contraindication? I already tell that cardiac conduction defect is a contraindication, absolute contraindication of VNS therapy. And relative contraindications are sleep apnea and obviously programmable shunt valve. And if any patient with bilateral or left cervical vagotomy came to us or cardiac conduction defect came to us, then go for the evaluation by cardiologist. So which type of seizure other than the LGS responds to VNS therapy? In LGS, two types of seizure is mostly responsible with VNS. There is atypical absence, that is most responsive, and second one is drop attack. For drop attack, obviously the corpus callosotomy is the procedure of choice. But VNS, some study shows that that is not inferior in cases of drop attack in comparison with the corpus callosotomy. But in LGS, most effective seizure that is reduced with the VNS is atypical absence. And they have tried mostly in cases of symptomatic generalized tonic-clonic seizure. In primary generalized seizure, they tried with juvenile myoclonic epilepsy. There is a case series of 8 patients in which near about 60 to 60% response in cases of JME also. And there is good response in cases of tuberous sclerosis, in our age group autism with symptomatic epilepsy, and also in status epilepticus. There is a case series of 6 patients where the response rate is 76% with VNS. But as there is no clear set of guidelines where to use the VNS, where to go for the surgery, so we have to decide case by case basis, and it obviously not depend on seizure type or etiology, not depends on age. In USA, there is no mention of age cutoff, but in UK group they mention the child should be more than 4 years, and there is no that not depend on sex, frequency of seizure, frequency of interictal spike, or number of co-administered drug. Okay, that case only. After this type of discussion, parents convinced with VNS. They are eager to go for the VNS. So they have some queries. We have already discussed that. What is the side effect? What is the pediatric safety? And what is the device safety? So side effect is transient and mild in cases of pediatric and adult in both the group. And usually the side effects are most commoner side effects are wound site infection, bradycardia, hoarseness, coughing, and paresthesia. And less frequently dyspnea, headache, or pharyngitis may occur. And it usually related to duration and intensity of the stimulus. One study is there where they go for an open label study, and the study population was 454. They go for the 3 years follow up for the side effect. In first year, their most common side effect was hoarseness, followed by paresthesia at 1 year. In second year also, most common was the hoarseness and headache. In the third year, the shortness of breath was the commoner side effects. So the side effects and the adverse events usually related to duration and intensity of the stimulations. That is the question: is it safe for my small child? Parents are very concerned regarding the 6 years old child. Is it safe for my small child? In comparison to adult population, they showed that the in childhood population, the higher tolerance is there. They tolerate more than the adult population. And though the technical complications and pain at the implant site may be more in cases of childhood population, but newer generation machine and also the smaller battery size, the complication is less in cases of childhood as well. And there is increased chance of salivation and hyperactivity in pediatric population. There is greater risk of wound infection compared to the adult population. And in some patients, there may be some sorts of swallowing difficulties may be there. And that is discussed thoroughly by ma'am, that is regarding the device safety. Diathermy is contraindicated in patient receiving VNS surgery as it may burn the tissue and also the nerve. And MRI is not contraindicated in cases of VNS, but VNS therapy magnet may inadvertently adjust the programmable shunt valve. That is the contraindication. If there is any type of BP shunt and that is programmable shunt is there, that is the contraindication for VNS therapy. The last one, what is the efficacy, what is the other benefits and chances of reducing AEDs? So usually in pediatric age group and adult age group also, the drug-resistant epilepsy is 20 to 30%. And VNS reduces and improves the seizure frequency over time. There is a classification for VNS therapy only, MACU classification. They divided the group in five group: class 1, class 2, class 3, class 4, and class 5. Class 1 is 80 to 100% reduction of the seizure frequency. Class 2, less than 80% reduction. Class 3, less than 50% reduction. Class 4, magnet benefit only. And class 5 is no improvement. Usually we term that VNS is effective if the MACU classification, that more than 50% seizure reduction is there. That is the MACU classification for VNS therapy. There is a study on efficacy of vagus nerve stimulation over time. They reviewed 65 patients. In 65, adult was 44 and children was 21. There is a retrospective study. And the response is greater. Response is more from 6 months to 10 years, up to 10 years. It depends on the time, obviously. That is discussed thoroughly in previous lectures. That is a multicentric study. That is the most renowned study in UK for effectiveness of the vagus nerve stimulation. And the efficacy in other childhood DRE. In tuberous sclerosis, the efficacy is 50 to 90%. In LGS, 50 to 65%. In Dravet syndrome, 36 to 63%. In Rett syndrome, which is most effective, is 86% in Dravet syndrome. Last one is the other benefits. What is the other benefits of VNS therapy? Obviously, it decreases the hospitalization and also the cost of therapy, as and the reduction of seizure is there. And there is a doubt regarding the dose of the ASM. I will go through the next slide. And there is a less chance of injury also. In LGS, there is frequent drop attack are there, and there is every chance of injury to the head. So in cases of VNS therapy, there is less chance of injury and less chance of SUDEP is there. There is significant improvement of the cognitive and mental health after the VNS therapy in childhood age group. That is one study that is tell about the chances of reducing the AEDs. There is a previous study. They told that there is a chance of reducing the dose and reducing the amount of drug in cases of after the VNS therapy. But similar study and bigger study and recent study refute that and that is the vagus nerve stimulation and drug reduction probably is not there. You should go with the same type of anti-seizure medication with VNS therapy also. And that is the take home, that VNS is a palliative treatment option indicated in which indication for epilepsy surgery are unknown. And symptomatic epilepsy is the main target disease. And besides seizure, there is improvement of the sleep quality, emotional stability, and there is less chance of or fewer hospitalization in cases of VNS therapy. Thank you. Actually, that is just only recap of the previous sessions.
Wonderful presentation, Dr. Paria. I just have a question for your patient that you showed where we did the VNS. Was the ASM drug tapering tried at any point of time, or you continue with the ASM that she was on already?
Actually, I have no practical experience. I have gone through 2 to 3 studies. One study from 2000 to 2001 from USA. They have go through the 26 patient, and that patient they showed that in 50% reduction is there in cases of 42 to 42% of cases. They could reduce the medications also. But newer studies and also the larger studies, they have not any evidence of reduction of the amount or dose of drugs. But obviously, effectively, there is reduction of the seizure burden with VNS. But they could not go through they could not go through the reduction of the ASM. Sir, in this regard also, I have no idea, but literature says in UK they recommend after 4 years of age, and USA there is no age group recommendation. And just in previous lectures I have heard that in India that is 7 years. That is 7 years in India.
What is the perceptible benefit that the patients or the parents they get after doing VNS when the patient is in drug refractory epilepsy and the dosage of drug is not going to be reduced after surgery? So what is the quality? What is the perceptible changes they observe? What is the
Actually, sir, there is reduction of seizure also. There is reduction of seizures. Then the complication of seizure should be reduced. In LGS, there some sorts of drop attack should be reduced. There is a less chance of injury also, and in cases that reduce the chance of SUDEP also. and also there is significantly improvement of the cognition. That is the main factor in our pediatric case group. That is significantly improvement of the cognition. The reduction of the seizure burden also improves.
Is there any study of what is the quality of life changes?
Obviously, sir. One study is there. I have shown that one study by Rivlin P. Published in 2014. They showed that there is a cognitive and mental health score is increased along with the physical health score.
Thank you.
Thank you.
I now request our next speaker, Dr. Arijit Chattopadhyay, sir, Senior Consultant Pediatric Neurologist at Apollo Multispeciality Hospital, Kolkata, to come on stage, please. Chairpersons for this session are Dr. Parthasarathi Datta, Dr. Manoj Kumar Bhattacharya, sir, and Dr. Shapal Mukherjee. Thank you.
Good afternoon, everyone. Shubha Navabarsha, Happy Bengali New Year. So I was asked to talk on VNS and neurostimulation in drug-resistant epilepsy. I have a few disclaimers to make. The first one is that the last VNS patient I dealt with was when I was training in neurology, pediatric neurology in the UK in London, and that was more than 20 years ago. There was a epilepsy surgical workup unit. I was part of that with this famous lady called Dr. Helen Cross, and we had all sorts of workups for epilepsy. But since that time, 20 years have passed since my return, and I have not dealt or had a chance to follow up any VNS patient. Because of two facts. Number one, it was not available until recently. And in Kolkata, for example, Amit and team had done the first case in Kolkata, or perhaps even in Eastern India. And of course, the exorbitant pricing, so that even in my practice, whenever I wanted to think about VNS, broached the subject, talked about the pricing, not in our city, to go to another city. Most of the patients or all the patients would sort of just look at me, blankly stare and say, this is beyond our expenses or capabilities. What I'm going to talk to you on, some of the slides are pretty old. Like there has been a generation of 20 years, so there's a generation gap of my learning with VNS. So I was sitting here from the morning and I've picked up so many new learning things, messages that I was not aware of, thanks to a lot of experts who are dealing with VNS on a day-to-day basis. So some of the data is picked up from the internet and of course not relevant to India, but basically drug-resistant epilepsy has a large potential of non-pharmacological treatment population. As you can see here, if, for example, in Europe, if there are 6 million patients with epilepsy, patients, the prevalence of epilepsy being about 8 per 1,000, you will have, it turns out to be 1.8 million drug-resistant patients who are candidates for non-pharmacological investigations. And this is for Europe. So in our country, which has a much higher population, you can just make the relevant conversions. The non-pharmacological treatments options for drug-resistant epilepsy, as you can see on the left, as discussed before, and this is very basic presentation, is cranial surgery. And all of that is written on the left. Of course, we also have the ketogenic diet that we discussed a bit about. It is effective, but it is very difficult to adhere to. The classical ketogenic diet is now out of favor, and we are going for the modified Atkins or the low glycemic diets. And then there's the vagal nerve stimulation or VNS therapy, which again, the emphasis, like Dr. Pradnya said, is that you cannot have a center that just does VNS. You have to have it as a part of all the epilepsy surgical options. So you have to have all the other types of, so it needs to be the comprehensible epilepsy surgical unit. And if you're dealing with pediatrics, then pediatric epilepsy surgical unit. You don't have a one-off, I'm a VNS center and we don't do anything else. Because you need that whole team who needs to make a decision which child is suitable for which procedure. So VNS therapy is an alternative option for many drug-resistant epilepsy who are not candidates for surgery. We heard this several times. This is either because the epileptic focus remains unidentified or located in the functional cortex. In addition, the side effects of this kind of surgery can be significant. For this reason, less invasive strategies like VNS should be considered as an alternative. And overall, VNS therapy is an efficacious neurophysiological treatment for patients with DRE who are unsuitable for curative resective surgery or who have experienced insufficient benefits from such treatment. As you can see on the left, if you look for the candidate for epilepsy surgery, and this is another way of how to show it, which are the patients suitable for epilepsy surgery? Of course, you have the temporal lobe, the mesial temporal, which is unilateral. These are the best patients. If you have neocortical lesions, very good patients, but as you become bitemporal, bifocal, multifocal, generalized, idiopathic, then it becomes less and less suitable for epilepsy surgery. There are also other influencing factors like expected seizure reduction, risks of surgery, comorbidities, living situation, patient preference, and of course the price and availability. This several people have shown epilepsy surgery algorithm, but effectively if you do have partial seizures or generalized seizures which are medically intractable, where epilepsy surgery is a no-go because of not possibly localizing by EEG, MRI, cognitive testing, etc., where surgery is not an option, then you can think about VNS both for focal surgery or partial seizures as well as generalized surgery. And this is another way to put the focal. So if you have, for example, temporal, mesiotemporal, it's very clear that you need resection, but where it is multifocal, extratemporal, where you are not very sure about the lesion, and then VNS should be considered as a possibility option for treatment. Similarly, in generalized, if you cannot localize, or if it is a syndromic type, like we discussed about Lennox-Gastaut syndrome, if there's a specific type of predominant seizures like drop attacks, then you may think about VNS, and there was a discussion about the differences or the pros and cons of doing corpus callosotomy versus VNS. But overall, there is sufficient evidence to rank VNS therapy for epilepsy as effective and safe based on a preponderance of class 1 evidence. This is quite some time back from 2018, but even at that time, there were more than 1,000 peer-reviewed publications on VNS therapy, which showed that it was 500 articles, safe in more than 150 articles, easy to use. There were certain economics discussed on this, mechanisms of actions were discussed, and review articles were also there. And there is ample evidence for the efficacy of VNS therapy for drug-resistant epilepsy. It also has shown to be protection against partial and generalized seizures. And what is the patient experience? Enhanced seizure control and improved patient outcomes than when treated early, sustained improvement in seizure frequency and significant reductions in seizure severity, significant improvements in the quality of life, and that was also discussed in a lot of these children. Like Pragnya was saying, in her cohort also there are some children who went back to school, and of course improvements in mental functioning, mood and behavior. This again has been discussed, but this was another study showing that if you use VNS early, so here VNS therapy was initiated within 5 years of epilepsy onset versus after 5 years of epilepsy onset, you are able to get a much better sort of seizure freedom or response. Like here it was 25.8% versus 14.3% who experienced a more than 90% reduction in seizure frequency at 3 months, which is substantial. And 15% of these patients who were seizure free at 3 months versus only 4.4% if they were treated late. So there's again evidence for early treatment. Safety profile, it has been discussed time and time again. These are the common side effects that everybody has discussed. Voice alteration seems to be a problem, but as was mentioned, because the stimulation is just in bursts which are short, and that is when the hoarseness happens, these patients sometimes are able to work around it, understanding when the voice is of better modulation. Other somatic side effects such as sleep apnea have been reported, and VNS therapy should be used with caution in the presence of bilateral or left cervical vagotomy that was discussed, as well as cardiac arrhythmias. The other therapy benefits is that none of the adverse effects commonly associated with anti-epileptic drugs are seen. There are no interactions between VNS therapy and common anti-epileptic drugs. The side effects occur mostly during stimulation, decrease over time, can be reduced by adjusting the VNS therapy output parameters, and VNS therapy happens automatically. Adherence is not a problem. Now we are coming to children. So in children, again, if you have about 1% of the pediatric population who have epilepsy, and 1/3 of these who have drug-resistant epilepsy, severe epilepsy during the developmental period is detrimental to intellectual and social maturation. Repeated seizures in children may lead to cognitive and behavioral impairments. So this may be an option for drug-resistant epilepsy where you are not being able to get seizure control, and that is having an effect on the cognition of the child. So some statistics: in 1994, VNS therapy was approved in Europe for the treatment of drug-resistant epilepsy, and there were randomized trials after that, and the overall demonstration was that 25 to 30% decrease in seizure frequency. However, that has gone up to now we are saying that 50% decrease in seizure frequency by more than 50%. Of the different types of seizures that have been found to be beneficial, as has already been explained or talked about, myoclonic, generalized tonic-clonic, and atypical absence respond much better rather than tonic or atonic seizures. The other two, which is DBS and RNS, they are not used in children, not licensed in children. I do not have any experience with them. So this is just, because I was asked to discuss all of them, this is just a comparison between the different, but the most usual thing that is being found to be useful in children or has been licensed is the VNS, particularly in pediatric epilepsy. This is an evidence-based guideline update in American Academy of Neurology, which shows that in children with epilepsy, using adjunctive VNS therapy for seizure frequency reduction better than not using adjunctive VNS therapy for seizure frequency reduction. In patients with LGS, in using adjunctive VNS therapy for seizure frequency reduction was better than not using. And in patients with epilepsy, VNS was also associated with mood improvement. But all of these were with weak evidence, level C evidence. This is again an older slide, as I understand, because this says that at that time it was approved by the FDA for 12-year-olds and over, whereas now we are hearing that it has been licensed to be approved for 4 years and over. But the thing is that it has to be drug-resistant epilepsy. It could be focal, it could be generalized. In addition, as we have heard, the FDA has approved VNS for other things outside epilepsy, like depression and other things that Dr. Milind alluded to. If you look at the NICE guidelines for VNS, VNS is effective and well-tolerated treatment for drug-resistant partial seizures. High stimulation paradigm is apparently significantly better than low stimulation. It is indicated as adjunctive therapy in reducing seizure frequency in patients with refractory epilepsy who are not suitable for seizure surgery. So, as Dr. Devgaonkar said, it is not curative, it is palliative, but if you have a particular child who will or you think will benefit and is having several such seizures a day, even a reduction of more than 50% for that child is a huge, big sort of bonus for the parents. So in summary, VNS therapy involves stimulation of the vagus nerves to provide an anticonvulsive effect in drug-resistant epilepsy. It works in a number of ways that has already been discussed. Effectiveness of VNS therapy in maintaining long-term and even increases over time, providing seizure frequency decreased and severity, increased quality of life, and overall maybe even an decrease in the economic burden. And as was mentioned before, the therapy actually takes time. You need to give it at least a good 2 years before you can say that this VNS therapy has not been effective for the child. And that is why both you as well as the family of the child who's had VNS need to be very patient. VNS therapy side effects are moderate and controllable. Thank you very much. Any questions?
Thank you, sir, for very nice summarization of the whole aspect of pediatric problem. One thing we have come to know in the last slide that VNS also increases cerebral blood flow. So my question is, that is a new concept rather, and for that we can use it in situations other than epilepsy also. So how it increases this cerebral blood flow, VNS?
I won't be able to answer that. This is just a slide taken from what you can see from all the references down below.
Yes, definitely.
And yeah, Diptanshu.
Yeah, I'll try to answer the question. I'm not sure whether this is the right answer, but vagus nerve has a direct association with the autonomic nervous system, which is being regulated here. And I think that function is directly related to the cerebral blood supply. I'm not sure, but this is a probable answer.
So we can try this in Moyamoya disease, VNS therapy?
I don't think we have enough evidence to.
I've not heard about that as an option in Moyamoya so far.
Yes, sir. You are the right person to give some comment.
We don't know still how it happens, because exact mechanism of vagal nerve stimulation is not known. In epilepsy, it works by inhibiting GABA A receptor mediated neurotransmitter inhibition. But after VNS, because VNS has used not only for drug-resistant epilepsy, it is treatment-resistant depression and a lot of other indications that Dr. Milind was telling. So after that, a lot of research happened with functional MRI, with cerebral blood flow study, and EEG, many things. And with the latest device, sir, this Aspire, it has been seen that EEG improvement in latest device as compared to previous device is better. But how it happens, people doesn't know. Cerebral blood flow study also shows it has improved, but mechanism we don't know.
Sir, I want to make a small comment. When Dr. Amit Ghosh is in the scenario, it was the time when Amit Ghosh was working for Moya disease, doing some bypasses.
Now also I am working.
No. It was a time when Amit Ghosh was working solely for revascularization. Then has come another situation when Amit Ghosh has started working on vagal nerve stimulation. So
Neuromodulation,
now we will wait for a time when he will establish that vagal nerve stimulation is working good for Moya disease. We are waiting for that day. Sir,
It is true that thalamic blood flow has increases in vagus nerve stimulation, not the total blood flow. It is only a partial blood flow on the thalamic side. There is nothing at the one. It is a generalized. Don't expect at this present moment that Mama will be. Yes. Also due to a neurosurgeon for therapy. Until unless you people help us, we cannot develop the new, or we will not be able to do epilepsy surgery and things. These neurologists
With due respect, my to establish a fully functional surgical workup unit. A pediatric neurologist all by himself is no one. A pediatric neurosurgeon all by himself is no one. You need a team. And believe me, I'm working in private hospitals on 2 attempts, tried to establish in Kolkata, talk about trying to establish such a center, but actually it is so hard work and time consuming and not that sort of cost effective for a private hospital which can earn crores in cardiac sort of surgeries that entertained me in that aspect. Sort of diet. 2 attempts in my first 10 years, I wanted to establish ketogenic diet as an effective therapy. You need a good dietitian for that. When I approached the dietitian, initially they were very enthusiastic. I went with them for a course. Once they understood how many hours of training they needed to give to the family, and this, I must say, was at the time of the classical ketogenic diet, the Atkins diet and all that was not that. As soon as they came back, they started avoiding me. As in, okay, sir, korbo, sir. But it sort of fizzled out. So I think everything here works down to finances, money and everything. Unless you have hospitals who are willing to do a lot of what you call charitable work, where they don't come back to see how much am I getting back from this sort of investment. So that is the reason I would say. So my time is up. I'm nearly 60 years old. So I hope some of the younger pediatric neurologists might, somebody sitting at the back, they might take a stake into trying to get the ketogenic diet and a good comprehensible pediatric epilepsy surgical unit up and functioning in Kolkata. Until such time that is not done, we do have to send our patients outside.
I have just 2 basic questions. If supposing there is no financial constraints, would you prefer your patients of DRE in pediatric age group to send them for VNS earlier than surgery?
I would take it up as an option because, as you heard, or you weren't here when Pradnya was talking, there are a lot of families who just do not want surgery on the brain.
Okay.
That is a complete no-no to them. And of course, all of them may not have money, but you're asking if money was not a factor. It has come across my mind that why not go for a non-invasive technique, especially as we are talking about LGS and drop attacks, or there may be other sort of syndromic epilepsies or drug-resistant epilepsies that might be amenable, but the major drawbacks is the finances at the moment. Of course, if I know that a child would qualify for epilepsy surgery, but the patients do not want to sort of undergo, then it may be an option. But that again, like was being discussed, it needs to be at a center which just has all the options, and maybe their center might say, okay, if you are not interested in surgery, we have VNS for you. So it is their center choice, not my choice sitting in Kolkata saying that you go for VNS. So I make the referrals as the epilepsy surgery workup rather than saying go for DN. I might suggest that this family is not interested in sort of the proper surgery and can DBS taken as an option, VNS be taken as an option.
Thank you. And the second question is, after VNS implantation, how much reduction of seizure numbers will make you think about reducing ASM?
Again, no experience. I haven't dealt with a case for 20 years. My limited experience, if I can recollect from 25 years ago, it wasn't a major issue if you were on drugs which were sort of having average side effects. If a child, for example, was on medications that would have sort of long-term cognitive effects, I don't know, something like topiramate was prevalent at that time when I was working. So topiramate has a negative effects on cognition, or phenobarbital, or maybe phenytoin. If those were the medications that somebody was on, then of course, or even clobazam for that matter, but that is more difficult, of course, because clobazam is very effective in certain types of seizures. You would be thinking about, but this would be done in very, very experienced hands. In people who have been dealing with these sort of situations and have got maybe 50 or 100 patients of VNS that they are following up. It's not very easy to do that, or you need really the experience to handle such a situation. So it's not recommended. Even if somebody comes to me, I wouldn't be bold to say that, okay, yeah, you've done the VNS, CSF reduced, let's start reducing. I would definitely need help or advice from some other experienced people.